All right. So these are different devices for oxygen. A couple of them we still use. A couple of them we don't. We still have to teach them to you. So this is the one that we no longer use. Okay? This was a manually triggered ventilation device, also known as the flow-restricted oxygen-powered ventilation device. Good news is they abbreviated it for you. You'll usually see it as FROPVD. Okay? We don't use them anymore. Know what they do, but know that you're not going to see them. They're dangerous. We couldn't use them correctly, so they took them away from us. Okay? Basically, this was a one-person BVM, right? So there's a good picture in your book. This one's a decent picture, but it's a mask. It has this device that goes on the top that's kind of a lot like those dust blowers that you put on like an air compressor, and it just has a trigger, right? If you squeeze the trigger, it would cause air with positive pressure to be forced inside the airway. This was awesome as long as people would let go of the trigger, right? Trigger for a second, let go. The problem is you would trigger for 2, 3, 4, 5 seconds or forget your finger was on the trigger, and you would overinflate their chest cavity, right? So, therefore, can't use it anymore, okay? It was for adults only, and this was the same procedure. Again, the nice thing is it allowed you to hold a seal with 2 hands and reach up and just grab that trigger with 1 hand, okay? As an EMT, you will have the option or the availability of transporting with ventilators. So here's the good news. You'll never put the ventilator on yourself, and you'll never mess with the settings of the ventilator. Okay, where you would use it is you work for an agency that runs inter-facilities or hospital to hospital. You go up to a hospital, the patient's already on a ventilator. You bring your ventilator in with them. The doctor will set your ventilator, the nurse will set your ventilator, and you'll transport them with the ventilator, right? What do you do if the ventilator fails? Bag them, right? It's just a battery-powered bag, okay? Everyone wants to drive from Texas to Washington really, really fast. Pull your BVM out and bag them. All the automatic transfer ventilator does is give the perfect rate of volume at the perfect rate. That's all it does, okay? These are, so there's breaths per minute, you set inspiratory time, and then you set tidal volume. It's really easy, okay? Things like this suck your oxygen pretty quick, right? So we have main oxygen tanks, which we'll talk about, provide oxygen a little bit longer. All right, so here's the importance of oxygen, right? This is the stuff for the next hour or so. We're going to beat oxygen until you literally think that no one should get it. It is a drug. It can hurt you, okay? You can administer it based on your overall evaluation of the patient's presentation and possible underlying conditions. Okay, the term I want you to write down is never withhold oxygen from a person who needs it. Notice how I didn't say from a person who wants it. Okay, never withhold oxygen from a person who needs it. I don't care if they got COPD. I don't care if they have all the risk factors of oxygen toxicity, which we'll talk about here in a second. Doesn't matter. If they need oxygen, give it to them. Okay? Where these problems started was we were giving oxygen to everybody, and we were finding out the side effects or the dangers of what oxygen can do. Okay? So it is a drug. We're going to talk about indications, contraindications, and so on. So the nice thing is we got portable oxygen tanks, right, in the field, lightweight, safe, dependable, and then there's the ones that are installed or fixed inside the ambulance. Usually these are the bigger ones, okay? We've had people who drive by MedStar and see them loading the large oxygen tanks onto the helicopter and want to know why MedStar has missiles. There is no firepower on MedStar's helicopters, okay? It's an oxygen tank. Yeah, me too. Some plenty of times where I was like, can you just low fly, drop one of those over top of the house, fix the problem? Okay, so oxygen systems, portables and fixed, right? That one's fixed. Congrats. These are oxygen cylinders. Now, it may not be a bad idea to know how much, like this, how many liters per, if you ran a non-regular, 15 liters, how long would it last, stuff along those lines, may be a good idea. Okay? Those are big ones. Nope. Yeah, it's in the book. because the NREMT hates EMTs. Yeah, we always thought it'd be nice, A, B, C, D, and E. Perfect, but then you got to have D, E, M, G, H. Of course not. I don't believe I put any of these on your test, mostly because I hate these test questions. Might be a good extra credit question. Well, what do they do that for? I make your tests in here, and I've taken them. NREMT? Probably not. Good? It's in your book, right? Good call. Pop quiz on Saturday. No, I was kidding. Actually, there's a real test on Saturday. Good on this one? Cool. All right, so oxygen cylinders, they got gauges, they got regulators, they've got tubing. We're supposed to use specialized wrenches, right? We're going to talk about valves and gaskets and all that good stuff. This is a drug. It is prescribed, right? Patients who have oxygen in their homes get it refilled by somebody else. We're going to talk about that. So don't let it drop or let it fall against an object. Say again? They don't want sparks, so usually like plastic wrenches. And we use metal stuff. We use probably stuff we're not supposed to. Leatherman's teeth, whatever you can open it with. It's one of those typical, like, you know, safety things. Yeah, biting the O2. This is the one that I'm a huge stickler on. In this class, you get one warning of leaving the oxygen cylinder standing up by itself. The next time I'll find a way to dock points, right? This tips over and knocks the top off, it's going to kill somebody. Okay? Yeah, I'll find a way to get you in deep trouble. It's a missile. Yeah, this is the one time it does become a missile, right? And it will go through walls and cars and buildings, and it'd be fun to watch the video later after all the paperwork, but let's not go there. Never allow smoking around oxygen equipment in use. So I always love the patients, you walk to their house, and they have the sign on the door, no smoking. And you walk in the door, and they're smoking, and you're like, is that for, like, your friends, or it doesn't apply to you, or whatever? I've now transported 2 people in my career that are dead from smoking with their nasal cannulas, right? It lit their face on fire and torched their entire body, right? We see this, it happens more often than we like to think, right? You walk in someone's house and they're puffing on a cigarette, you'd be like, hey, put your cigarette out. And they'll go, why? And you go, because my bag has an oxygen tank in it. They don't want to put it out, then you leave, right? It's a safety issue. I love patients who call for shortness of breath, and you can't even see the patient because of the haze of cigarette smoke that's in their house, right? And they're like, it's so bad. It's never been like this before. Can I have a cigarette before I leave? Never try to move an oxygen cylinder by dragging it or rolling it on its side or bottom, right? Pretty self-explanatory. So pressure regulators, the purpose is it provides a safe working pressure of 30 to 70 psi. No matter the size of oxygen tank, your oxygen tanks will read full at about 2,000 psi. Okay? What is the safe residual volume for the low end of oxygen cylinders? 200 psi. The downfall is most agencies, we chain tanks at 500, right? But the tank is rated to be at no less than 200 psi. Never suck those things dry, right? It can cause damage. They say you're not supposed to do it. We do it all the time. Flow meters. This allows control of flow of oxygen in liters per minute, right? LPM. Okay, we're going to talk about nasal cannulas and non-breathers and that kind of stuff. Low pressure flow meters, high pressure flow meters we'll talk about. Low pressures where you're going to put like your nasal cannulas and stuff like that. Your high pressure, I'm going to show you, this is rated for CPAP, but, oops, sorry. This is what's usually mounted in your ambulance, right? This is the low pressure flow meters. These go on our portable tanks. Your nasal cannulas, your non-breathers hook up right here. Your CPAP screws into this right here. Okay? You get a chance to mess with these today. So humidifiers, we're going to talk about why these are great here in a second. Not a lot of places have them, which really sucks. Long transports, these will make your patient's day, right? Oxygen dries out your nose and your mouth, can cause some big issues, can cause bleeding, can cause some discomfort. So humidifiers decrease that, which increases their comfort. So if you have this as an option, awesome. Long transports, like I said, a lot of those interfacility ambulances have these. It's just not always it's not a requirement. So basically, it's just saline that hooks up to the oxygen that just basically provides some moisture to it. All right, hazards of oxygen therapy. The most common misconception: oxygen is not flammable, right? We've been telling people forever that oxygen's flammable. That's totally false, okay? If oxygen was flammable, if you lit a match in this room right now, the room would explode, right? Because it's got 21% oxygen. It would just go, and we'd all be dead, okay? It supports combustion. So in a small space, it saturates that area. That's why nasal cannulas, they can smoke most of their life with nasal cannulas. And then one time, it'll be pressure or whatever saturates enough right in front of their face, and then it ignites, right? And then it lights their face on fire. And they run around, and they call 911, and they die. Pretty straightforward, okay? Towels, sheets, clothing, spaces, stuff like that cause big issues, okay? So,
John, is that why ORs, they do whatever they can to keep the static electricity down?
maybe, I don't know, maybe?
I mean, there's a lot of oxygen in an OR.
Yeah, sounds like a intelligent theory, but I don't know. Sure, that's exactly why they do it. I got nothing. Yeah, I'll just lie to you. We're going to beat this a little bit more, but there is some rare medical situations. We're going to talk about oxygen toxicity. We're going to talk about air sac collapse. We're going to talk about all these things, so we'll come back to that. Let's see here. So administering oxygen, non-rebreathers, right? You'll see me write it as NRB, okay? NRB is the very best way to deliver high concentrations of oxygen to a breathing patient. Okay, it's in red for a reason. I would say probably 10 or 15 more test questions are on nasal cannula, non-rebreather, that kind of stuff. Okay, non-rebreather, very best way to deliver high concentrations of oxygen to a breathing patient. Easy? That's non-rebreather. So here's a couple of things that make it a non-rebreather. See this carbon disc right here? There's a carbon disc right here as well. Okay? If it has these carbon discs, it's a non-rebreather. When they exhale, all of their exhale, it pushes against that carbon disc and allows their exhale to leave the mask. So when they inhale, theoretically, it should only be pull air out of this bag, right, which is filled with pure oxygen. When we are doing non-rebreather, this is considered to be high concentration of oxygen. Okay? There's non-rebreather. So I will tell you that bullet point number 1 has caused more arguments of any class I've ever taught. Okay? Respiratory therapists will tell you it doesn't deliver anywhere near 100%. They'll tell you it's closer to like 90%. Okay, great. Right? Anything above 60% is considered to be high flow anyways. So it provides high flow oxygen, right, from 80 to 100. Sometimes you'll see it as 80 to 90. Sometimes you'll see 90 to 100. It's kind of all over the place. Okay, optimum flow rate for your non-rebreather, 12 to 15 liters per minute. What's the lowest you can do? Anybody know? Optimum is 12 to 15. What's the lowest possible? 10. Right? At 10, the bag will not stay inflated. Or anything less than 10, the bag won't stay inflated. What you don't want is them to inhale and that bag be empty. Okay? Because the bag's empty, the carbon discs suck against that piece of plastic, and they're trying to suck against a plastic mask. Okay? Nasal cannula, right? You'll see us put it as NC, not like North Central, crappy school. Just kidding. How many of you went to NC? Only one of you? Awesome. 2 of you. Perfect. Best choice for a patient who refuses to wear an oxygen face mask. Okay? This is kind of old school. Notice how it's worded. This is the best case for someone who won't wear oxygen. This is the best case for patients who don't need high flow oxygen. Right? Because nasal cannula, you never get anywhere near close to high flow. Okay? This is low concentration. So, nasal cannula is the best source of oxygen for patients who you're giving it that need low concentration. Make sense? That's what it looks like. It's got these little prongs. Those go in the nose. That plugs in. That easy. So your nasal cannula provides about 24 to 44% oxygen depending on your liters per minute. I will tell you, please do not administer more than 6 liters per minute in their nose. Okay, it's not tolerated very well. Okay, what's the lowest, you think? 1 or 2. Yeah, I've never seen 0.5. I'm sure you could. Most patients like 1 or 2. If they're on HOMO2, 2 is the most common, right? If they're on 2 liters and their saturations suck, do not just put them on 2 liters on your own O2, right? Bump them up. Bump them to 4. Bump them to 3. Bump them to 5, whatever. Just don't run it more than 6. Okay, they don't tolerate that very well. Partial non-rebreathers, this is pretty straightforward. It basically doesn't have a one-way valve in that reservoir bag, right? It just doesn't have that carbon piece of paper. So it allows, when you exhale, it puts some of your rebreathed air into that bag. So it decreases the amount of oxygen you're actually getting, about 40 to 60% at 9 to 10 liters per minute. I have never in 10 years of my career ever used a partial non-rebreather, right? We always use non-rebreathers and nasal cannulas. In fact, the only way I know to have one of these is if I rip the carbon piece of paper off the non-rebreather. I don't know why you would do that. Another thing, so Venturi masks, these are cool in theory, right? This allows us to mess with specific concentrations of oxygen and mixing air, right? This is what it looks like. Never seen one in pre-hospital. I am told that this is really common in the hospital setting or in more of a critical care or inter-facility setting. Okay? Know what it does, okay? But other than that, that's about as much as you need to know about it. I don't think we even have one here. Done? You're welcome. Make sense? Whoops, sorry. So these trach masks, so these get placed over the stoma, which is that surgical opening right in their throat. You can provide oxygen at 8 to 10 liters per minute. This is what it looks like. Okay? Really unique circumstance. We're going to talk about special needs patients. Every class I attempt, I have a very close friend of mine who is paralyzed. He's from the neck down, and he's in a wheelchair, and he's on permanent BiPAP and CPAP, and he's got all kinds of medical problems. We try to get him into EMT classes every single time, and it never works. I'm really trying to get him in for you guys to be able to talk to, work on, take vitals and stuff, and you'll get a chance to kind of see some of the specialized devices. You take him to the hospital, and it takes like 30 minutes to get all of his equipment set up and ready to go off of power onto battery. And then once you're in the ambulance, he goes off of battery back onto power. And then when you get him out of the ambulance, he goes off of power into battery. And you do this like 4 and 5 times when you transport him. So hopefully we'll get a chance to have him in here and get a chance to ask him questions and stuff because he's a really good resource. And he's a vulgar little kid. He's like 22, and he's about yay tall. He doesn't have any use of his legs. He's got minor use of his arms. He's got muscular dystrophy, a respiratory condition, and something else. And he is the most vulgar person I've ever met in my entire life. I've seen him trash on nurses and doctors, and he's fun. He's really, really mean. I'm nice to him, therefore he's not mean to me, and I've known him since he was a kid. So here's oxygen toxicity, okay? So this is the scary side of oxygen. So I will tell you that we're working on presenting this more and more to EMTs because we've done a really disservice of EMTs in the past. So this stuff's a little bit intense. If I start rolling a little bit too fast, please say, hang on. Not a lot of this is in red, but it doesn't mean it's not important, okay? It not being in red means it's not going to be on your test, okay? Not specifically. Does that make sense? So I pulled this from an article that basically was to pre-hospital providers about what is oxygen toxicity. Because for the longest time, we were totally oblivious to this. So pretty straightforward. We've talked about this before, right? Adequate oxygenation delivery is essential. Your body has fail-safes in place that is this compensation is inadequate O2, right? But if that doesn't fix itself, within minutes, hypoxia occurs. How long does it take your brain to die from lack of oxygen or start to die? Anybody know? Say again? Yeah, 2 to 4, right? Your heart is about 6 to 10, okay? Then outside of that, muscle's a little bit different, and like skin and eyes and those kind of organs can live a lot longer without oxygen. Brain's the first to go. Cardiac follows right behind it, okay? That's why oxygenation is so important. So we talked about chemoreceptors, right? Don't start reading ahead because it'll scare you. So we talked about chemoreceptors, right? What's the purpose of a chemoreceptor? I'm going to get rid of it so you quit reading. Right. So it's like it's a gauge, right, that tells your brain, it reports back to your brain how much you're going to breathe. Now you have peripheral chemoreceptors, right? They're located in your carotid arteries and in the aortic arch, okay? These are the ones that are in charge of recognizing hypoxia and hypoxia only, okay? This is like your secondary chemoreceptors, okay? This isn't your primary ones. So it recognizes the changes in oxygen and triggers when PaO2, which is the amount of oxygen that's actually dissolved in your plasma. We're looking at just your blood. It looks nothing about your hemoglobins, okay? I will tell you that PaO2 runs about 80 to 100 millimeters of mercury, okay? Anything less than 60 is when your body picks up on the fact that you're hypoxic, okay? 60 is equivalent to 90% on your SpO2. Okay, we're going to compare SpO2 and PaO2 here in just a second. When you administer high flow oxygen, more oxygen gets dissolved into your plasma. You mess with this percentage, right? And it's not, I think it's like 10% of oxygen that you breathe in gets dissolved in your plasma. Okay, most of it gets used in oxygenation, but about 10% gets dissolved. Now, one of the things that happens, if you provide supplemental oxygen over a long period of time, if you make your body dump more oxygen in your plasma, you make your blood acidic, right, which it becomes toxic. And we're going to talk about a couple different times here in a second. Your central chemoreceptors, or your primary ones, this is your primary control over breathing, right? This is your like plan A. This is in your medulla, and it's kind of put throughout your cerebral spinal fluid. That's what CSF stands for. This is the one that if your CO2 level rises, by that case, your hydrogen ion levels rise, causing your pH to decrease, right? How many of you took chemistry? Lower the pH, the more the acid, okay? So as CO2 rises, your pH falls and your blood becomes more acidic, okay? And your brain says, I got to breathe faster. So it blows off CO2, okay? CO2 is predominantly what makes, for this case, CO2 is what predominantly makes up your pH levels, okay? In diabetics, who let's say their blood sugars, normal is 80 to 1, or 60 to 120, right? Let's say their blood sugars are 900, right? That makes their blood very acidic. Therefore, their body is going to breathe at a high rate to try to blow off that CO2, right? Two ways it does. It breathes faster, and you pee more, right? Get it out of your body and blow it out using respiratory, okay? So the air we breathe, FiO2 is the amount of air that's in, or the amount of oxygen that's in the air, right? Right now it's about 21% oxygen, less than 1% is carbon dioxide, and it's 79% nitrogen, okay? Those of you that are really, really smart or can guess extremely well, what is the purpose of the nitrogen in our bodies? Anybody know? When you breathe in 79% nitrogen. So how does your body use this? Anybody know? You can go that far. What else? Is this a large molecule or a small molecule? Large. Okay? This doesn't go into your capillaries. Nitrogen fills your alveoli and creates the pressure to make them stay open. That's its sole purpose, okay, in this case. So nitrogen fills your alveoli, and they're a big molecule, right? Think of a water balloon, and you fill it with marbles. If you keep a bunch of marbles in that water balloon, it'll stay expanded, right? That's the purpose of nitrogen. What it allows is your alveoli are open, and it allows the oxygen to go in, the CO2 to come out. When you exhale, it blows that nitrogen away. Now, you don't always use all of your alveoli. Like if you're sleeping, you might only have 10% of your alveoli open, right? Because you only have to have a little bit of oxygen. Your rate's slow, but your body's maintaining it. So we're going to talk about nitrogen washout here in a second, because this is also one of the dangers of too much oxygen. We're going to talk about it here in just a second. Okay? So how do we measure oxygen levels in the field? Us as EMS providers, what do? SpO2, right? UV light clips on your finger, gives me a percentage. Okay? This is great as long as there is no chance of carbon monoxide poisoning. Okay? The most accurate way is actually what's called the SaO2, which is arterial oxygenation. Bad news is it requires a needle, and you do it in the hospital, because they're actually poking an artery and looking at the saturation that way. Okay? So the best way we've got is SpO2. Okay? The downfall is SpO2, the UV light we use, carbon monoxide and oxygen have the same transparency to light. Okay? If you clip it on someone's finger who's been in a house fire for the last 4.5 hours, they'll come back with oxygen saturation 100%. It could be 89% CO, but it will come back as 100%. There's no way for us to distinguish between the two of them. Okay? I want you to know the reason why this is bolded in red, underlined in italic. Okay? This only applies, these dangers only apply to high flow O2. Nasal cannulas, you don't have to worry about any of this. Okay? This is only the turn of stop putting on rebreathers on every single person you come in contact with. Okay? So when delivering less than 60% of oxygen to healthy lungs, we don't have any cases of oxygen toxicity. Okay? Less than 60% of pure oxygen to healthy people. Now, if you deliver more than 50% of oxygen to sick people, that's when we start talking about oxygen toxicity. Make sense? All right. So here's the first thing that oxygen does that's the bad side. Okay? The most common one, okay, this is the biggest danger, the plastic that we use in our non-rebreathers and our nasal cannulas and the oxygen actually causes your skin to break down and cause some long-term irritation. Okay? If you go on patients who are on chronic oxygen, what you'll see is they have padded nasal cannulas, usually padded behind their ears, and a lot of times padded across their cheekbones, right, to keep that plastic off of their face because it can cause damage. Okay? Libby, go ahead.
Hypothetically, could somebody also have a problem, like, say they had, like, skin irritation, like, on their hands, or is it just the face because it's
Usually it's just it's direct contact. Usually it's not like a sore that happens throughout the body.
Well, no, I meant, like, say it's like an EMS worker using it, maybe he's like rubbing against it. Could he get a skin irritation?
Usually it's long term. So unless you're there for hours, not normally.
Okay.
So, like I said, normal people are on oxygen, or normal people who normally are on oxygen long term, have padding on that nasal cannula, right? You will never see someone who is prescribed non-rebreather oxygen. Okay? It doesn't happen. It's nasal cannulas, that's the only option. Okay, so there's problem number one. Problem number two, this is the drying of the nose and mouth. So when you give supplemental oxygen, it has no moisture to it whatsoever, right? Almost zero moisture content. Now the downfall is, in your nose and your mouth, the mucous membranes will actually give it moisture to prevent damage to your alveoli and your bronchioles as it moves its way down, right? So therefore, if it's giving up its moisture, long term, you're going to dry out the nose, you're going to dry out the mouth, you're going to cause bleeding, you're going to cause cracked nostrils, you're going to cause some discomfort. And then what happens long term is you start getting damage in the nose and in the mouth. Kathy?
Could that be like a part of like an invisible thing?
Yeah, right? Because in a lot of cases, it's that dry, cold air a lot of times causes it to get real cracked and real dry. So the simple fix to this is humidified oxygen. Go ahead, sir.
Just a question, when medics intubate somebody,
Mhm.
does that, if they were on that for a long period of time, would that also damage
Yeah, I will tell you that, I don't know the exact number, but I think it's over 50%. If you get intubated, it's over 50% chance that you'll never come off a ventilator. When you get intubated and go on a ventilator, your body gets lazy, right? A lot of patients never come off of them, right? And it's because the way your body's used to working, we flipped it, and now your body has to like relearn how to breathe all on its own. Yeah, it's not, intubation is getting frowned upon more and more and more as time goes on. Like,
You talked about the humidifiers that they attach.
Mhm.
Could you aspirate some of that?
no, because usually it's aerosolized in the device, and so it's not like water running down the tube. It's actually humidified right there in that chamber and then gets put into the tubing. It's a really good question. All right, so here's one of the scary ones, right? This is the nitrogen washout, okay? We talked about nitrogen that normally helps that alveoli keep its pressure, right? Above 50% oxygen, nitrogen is displaced by supplemental oxygen, and now oxygen is your primary gas, right? Because if you're given 80% oxygen, then you're only inhaling a small portion of nitrogen. Holy cow, I almost want to say nitroglycerin every single time. Okay? Oxygen is meant to go through the capillaries in the bloodstream. So what happens is your alveoli, this is this air sac collapse. If you want to be really, really smart, absorptive atelectasis. Okay, that's the term. This is nitrogen washout. Okay? Above 50% oxygen, and again, it takes only about 15 minutes. 15 minutes at 100% oxygen will wipe out all your nitrogen, and your alveoli will actually collapse, and you'll stop getting air exchange. Right? Pure oxygen literally made you quit breathing. Okay? When I was learning about, because this was something I'd never heard about until literally at like 4 o'clock today. I would tell you, I hate reading. Have I said that yet? I hate everything about reading. There's words, there's punctuation. I don't read good. I don't spell good. I don't speak good. I hate all of it, right? So I was reading this article, and Gary was here, and I was like, you ever heard about nitrogen washout? And he was like, duh. I was like, great. Explain it to me, right? This doesn't happen horribly often. Where this gets dangerous, Gary says, and he's the paramedic instructor, and he's like the man. Okay, let's just go back. Now, this is like post-cardiac arrest. Okay, this is sick patients who you're giving pure oxygen to. This doesn't happen to normal people. We can take everyone in this room, give you 15 liters non-air breather for the next 6 hours, and it won't do any of this, right? Because you have normal, healthy lungs. Damaged lungs, sick lungs after cardiac arrest or low perfusion or something like that, that's where you run the risk of this. Okay? So this is the one that we worry about more often. Okay? This is that hypoxic drive I was talking about. Okay? So chronically high CO2 levels, like you have with COPD, what happens is because your central chemoreceptors, right, this was your primary, because of the fact that the COPD patients are always at high CO2 levels, their primary chemoreceptors actually become desensitized to that and quit looking at it, right? And they go back to their fail-safe, which is that hypoxia side. So now their body will only breathe based on hypoxia, which is the opposite of what your body's used to, okay? So what happens is, on average, about 45 minutes of high flow O2, anything over 8 liters per minute increases your patient's chance of death with COPD and high flow oxygen. Okay? Now, I will tell you that a couple of years ago, we were like, this never happens, because we were actually told it was hours, right? So we're like, this would never happen. I can't think of a single circumstance where you'd have a patient on intubated that long. Until a year and a half ago, it happened in Deer Park. It was a snowstorm. The fire department got there. The ambulance was coming from Spokane. Took us about an hour to get there. Fire department had them on 15 liters the entire time, so 15 liters about an hour. Ambulance got there. He was still having respiratory difficulty, so they left him on the 15 liters for the hour and a half drive to the hospital. Right? So he's now been on high flow oxygen for 2.5 hours. They pull him into the ER, and he quits breathing. Right? They intubate him. They stick him on a ventilator. He lives on a ventilator for 2 days and dies. Right? And they tell us that was the exact reason. If we would have put him on 15 liters for 45 minutes, and the fire department been like, look, his saturations have gotten better, his oxygen demand has lowered, let's put him on a nasal cannula, he'd still be alive. Right? This is Oxygen is a titrate to effect drug. Okay? Their saturations are 88%. Great. Put them on 15 liters. The second they get to 94%, give them 10, 15 minutes for their body to catch up, and then take away the non-rebreather and put them on a nasal cannula. If they maintain saturations, don't put the non-rebreather back on them. Right? It's literally that easy. We just don't do it for whatever reason. The numbers down here are not in red for a reason. Only with COPD patients, this is your goal for saturations. Okay? That looks substantially low, right? This is what they're used to. How many of you smoke or have smoked before for long periods of time? Anybody wants to admit it? Didn't think so. That's your saturation, right? COPD patients and smokers, this is what your saturation sits at. It's supposed to be like 98 to 100, right? But this is typical. So our COPD patients, it's not uncommon to be 89%, right? Breathing a little bit fast because they're always maintain or an increase to CO2 because their body doesn't breathe as well as it's supposed to. So bleeding and facial injuries, right? We talked about how much facial injuries can bleed, so bleeding can obviously be a big issue. Suction is still going to be the aggressive one, right? Aggressive suction, advanced airway maneuvers can be necessary. Obstructions, airway is still number one. Okay, let's not forget, everyone kind of gets caught up in breathing. Don't forget airway is number one. Dental appliances, if they're in the way, move them. If they're not in the way, leave them alone. So here's kids. So a couple things about kids. One, they burn oxygen twice as fast as adults. Okay, they need oxygen a lot more often than we do. The second one, their body solely relies on their respiratory system. I will tell you, dead kids, right? I use that term probably, it's a bad term, but that's the best term I got. Dead kids, right? Respiratory problem 99.9% of the time. Little kids do not have heart attacks. They don't have cardiac damage. They don't have tamponade. They don't have any of that stuff. It's always a respiratory problem that leads to them being in cardiac arrest. Pneumonia, obstructed airway, hypoxia, seizure, something like that leads to the death of their heart. Their heart is never the cause. Okay? We've talked about that. Assisting with advanced airways. So we talked about supraglottic airways on Tuesday, right? That one's considered to be a blind insertion device because you don't have to have any visualization of the airway. Okay? Unlike ET innovation, that requires you to have the visualization of the glottic opening. That's a really poor look at what innovation looks like. Okay? The maneuver we're going to talk about, you can write down burp, B-U-R-P. Okay? And we're going to talk about how that works here in just a second. So here's what you can do during intubation. Okay? Maximize oxygenation prior to procedure. I will tell you this is one of the things that we're working on here in Spokane County. What would happen is we would be bagging a patient. The paramedic would go, okay, it's time to intubate. So you'd bag the patient. They go, okay, I'm going to intubate. So you'd stop bagging. They got to put that laryngoscope blade in their mouth. They got to lift up. They got to find the vocal cords. They got to put the tube in. They got to push 10 mLs of air into the syringe, which inflates the cuff. They got to put the BVM on top of the bag or on top of the tube and then bag, right? If they can do that in 25 seconds, perfect, right? If that takes them a minute, what's happening that entire time? Say again? Hypoxia, right? So we were looking at ways to find out how can we fix that hypoxia that occurs during intubation. Our first idea was what we called hyperventilation. So before they would do ET intubation, they would ask someone to hyperventilate. So you would bag the patient at a rate of about every 3 seconds, which the idea was you would dump excess oxygen into their bloodstream to allow them to not breathe for a longer period of time. Does that make sense? If you put in twice as much oxygen into their bloodstream, they could survive twice as long without us giving them a breath. Okay? The idea is we didn't like the term hyperventilation. So they started saying, let's pre-oxygenate them. Okay? How many of you have read your skill sheet for supraglottic airway? How many of you recognize the term pre-oxygenation? Because we're going to do it before you drop a King Air. Okay? King Air should take you less than 30 seconds. Takes you more than 30 seconds, go back to bagging. Okay? So Pre-oxygenation is just good mask seal, right? Good breaths, and make sure you're delivering adequate amount of oxygenation leading up to when you're going to stop that. What paramedics are doing now is what's called apneic oxygenation. We actually take a nasal cannula and stick it in their nose, right? These patients are unconscious and not breathing because we're putting in an ET tube, right? Take a nasal cannula, stick it in their nose, and we turn it up to 15 liters per minute. We let it run. The entire time that they're intubating, that patient is getting 15 liters of oxygen through their nose, which is decreasing the chance of them having that damage from hypoxia. We've thought about trying to do it with the King Air. You can do it with the King Air, but apneic hypoxia takes about a minute to occur. So as long as you've dropped the King Air within a minute, you're fine. You can do it because it's giving them pure oxygen the entire time, but it's not as much of a goal as we are with the paramedics. Go ahead, sir.
Doesn't the King Air block off, like the larynx?
No, because it gives you direct access to, I mean, it goes in the mouth, so when you bag, it's supposed to be pulling some of that. But realistically, until you inflate that cuff, they're getting oxygen that entire time. Does that make sense? And the other one is if it's in your nose, it's some of it's getting in through your bloodstream through the mucous membranes of your nose. Right? Any other questions? So we talked about maximizing oxygenation, right? Position the patient in the sniffing position. Make sure they got a really good head tilt chin lift for the paramedic. Okay, I'll let you guys get a chance to, we'll use SimMan, and I'll show you how much fun it is to intubate. Okay, you got to reef on their face pretty hard. Okay, I will tell you it's not uncommon to hear paramedics do this improperly that snap teeth with the laryngoscope blade. Okay, because what they do is they pull straight back, and it just destroys your top jaw. Breaks your teeth, it can crack your top jaw, all kinds of nasty stuff. Okay? Cricoid pressure, so your esophagus is posterior, your trachea is anterior, right? In large people, you'll hear paramedics say they're very anterior, which means looking down the laryngoscope blade, they cannot see the trachea. Okay? In order for ET intubation to work, you have to see vocal cords. Okay? So what they want you to do is what's called burp. Burp is backwards, upwards, right pressure. Okay? Backwards, upwards, right pressure. You find that cricoid ring, right? That cricoid thyroid cartilage we talked about on Tuesday. You're going to put one finger on either side, which is what this guy's doing right here, right? One finger on either side, and you're going to push straight back, flex it upward, and push it to the right. And what that does is it actually smashes the esophagus and brings the vocal cords into view of the paramedic, right? Theoretically. Okay, sometimes it works, sometimes it doesn't. Usually suction is what we go for first. Okay, there's blood, there's vomit or something, they can't see vocal cords. Push back, up and right, hard enough until they tell you to stop. Once they tell you to stop, hold it, because they got to get that tube to pass, right? It's not one of those like push it back, they can see it, and then just let go. Okay, hold it in place till they get that tube to actually pass through the vocal cords. Does that make sense?
Are we pushing that to our right or patient's right?
Patient's right. Good question. Just checking. Don't do your right. See what happens. You can do it backwards, right? Backwards, bottom, left, and just see what happens. I don't know. Yeah, pull down. So confirmation, when either King Air or Combi tube or ET tube, you have to confirm tube placement in two ways. Okay? You need one mechanical way and you need one electronic way. Okay? So what are some ways that you can think of that would confirm that your tube is in the right place? Let's start with King Air first. Chest rise number one. What else? That's a mechanical way. What else? SpO2, a little closer to electrical, but it's a good idea, right? Pulse ox increases, chest rise and fall. What else? Color change, right? We're going to talk about CO2 stuff here in a second. What else? What else do you think? What else would you know for a fact you're in the right place? So, but not necessarily, because if they're in cardiac arrest, they wouldn't have a pulse, right? What else? Lung sounds. Take your stethoscope, put it over the lungs, and you're actually hearing air go in the lungs. Okay? Anytime that you get gastric distension or it looks like a little alien's growing in their stomach, take your tube out. Okay? It's putting too much air in the stomach. The electrical way we have of testing these is what's called waveform or end-tidal CO2. It actually is that CO2 detector that goes on the tube and gives us a number, right? We were talking about that CO2 washout, right? Where it gives us a, if end-tidal CO2 is 30 to 40, the tube's in the right place. Okay, we're going to talk about stuff with King Airs today. Securing tube in place. We weren't really harping on this on Tuesday, but tonight we're going to. Once you put the King Air in place, you've inflated the cuff and you've attached that BVM. You cannot let go of that King Air until it's secured, right? Because that BVM will pull on that King Air one side or the other. So you got to hang on to it. Remember how I was showing you guys to wrap the tube through your fingers and put your finger on top of that BVM? Hang on to that until someone secures it. You can use tape. There's also a device, it's called a Thomas tube tamer, and it's a plastic piece that actually crimps the tube, has a bite block that goes in their mouth and velcros around their head. Allows them to not bite the tube that they seize, allows the tube to stay in place, and it secures the tube in a fairly permanent position. So once the tube goes in, you can't let go until it's secured. Make sense? Once you ventilate the patient, okay, advanced airways in place, King Air, Combi tube, ET tube, iGel, LMA, whatever it is, the rate changes to every 6 seconds. Okay? It was 5 to 6 seconds before, right? Now it's every 6 seconds. Why do we decrease the amount of oxygen we're giving them with an advanced airway? Say again? How is it more efficient? Yeah, you're isolating the trachea, right? We're decreasing the chance of that 500 mLs going anywhere but just the trachea. So we don't have to give as much. So slow your rate down a little bit, right? Without an advanced airway, we're looking at 10 to 12. With an advanced airway, about a rate of 10 per minute, okay, about every 6 seconds. Does that make sense? Let's see here. Assisting with trauma intubation, this one's a pain in the butt. Okay, you can't head tilt chin lift and they have to intubate. Your job will probably be that Burt maneuver, right? Because you're really going to have to utilize that to allow that to, those vocal cords to come into view. Blind insertion, we talked about King Airs, right? We talked about LMAs. They say it doesn't normally require the head in the sniffing position. It's a good habit, okay? Questions? That was brutal. We got one more scenario to work through and then we'll take a break. All right. So you're all EMTs. Congrats. It was that easy. You're all dispatched to a structure fire with a person trapped. Fire units arrive, report fully involved structure fire. As you're pulling up to the scene, you hear the rescue is coming out of the structure with an unconscious patient. Okay, right now, what are some safety things you can think of? That's the only safety thing you can think of with a fully engulfed structure fire? Fire. Untrue. Right? I'll tell you, we're right up in the front of this house, on fire or not. Oxygen tanks, right? Keep those away from fire. Okay? Say again. Falling objects. Right? Then comes the medical side, like Brandon's saying. Going to be CO poisoning. What other poisonings can they have in an enclosed space? Anybody know? So more commonly known as cyanide poisoning, right? Burning furniture, stuff like that. We actually have cyanide kits to give to these patients. Cyanide poisoning, CO poisoning. Then comes the other stuff like burns, right? If you inhaled hot air, it causes your trachea and all that soft tissue to swell closed. So airway, enclosed space fires, airway is your number one concern, okay? So we stole this video from YouTube. If you've seen it, it's a good video. We're not going to play the entire thing. But this is a head cam, if it plays. Please play. As soon as I get there. timeout. Got really dark in here.